I would like to extend my warm good evening to all those who are present to attend this webinar. As ma'am has already highlighted, today's webinar, we are going to see about the anatomy of eye. So we have divided it into two sessions. As ma'am pointed out, I am going to be dealing with the anatomy of the structures which are present around the eyeball. And my next speaker is going to be speaking about the anatomy of eyeball proper. So as with my knowledge, I understand for most of us, anatomy is like not our favorite topic because we have lot of facts to remember and it is like too many things to remember. But for example, consider a building which will have a foundation stone which has to be laid very strongly in order for us to build upon it uh, to have a whole structure. Similarly, anatomy is similar to the foundation stone of a building. So we have to have a strong knowledge on anatomy of the eye for us to add more facts and info to be having a strong knowledge on the clinical practice. So with this intro, I'll be moving on to my slides. Here, all of you, please take a look at this image, which is showing an overview of an external eye anatomy and all the structures surrounding the eyeball. As I move on to the next slide, please go through these 5 points. As you may see, these points may be very random and not correlating with you at this point of time in this presentation. But I'm sure by the end of this presentation, all of you will have a clear idea of all these structures. So moving on to my topic proper, the orbit and appendages of eye. So what is appendages of eye? It is nothing but all the supporting structures which are present around the eyeball. So the appendages of eye consists of the eyelids, eyebrows, the lacrimal gland and its passages, the extraocular muscles and conjunctiva. So my first topic is going to be on orbit. Orbit is nothing but an eye socket or a bony socket in which the eyeball is placed. As you see in this picture, and most of you will know, this is a pyramid. I've shown this picture here for you to make it very clear that orbit is nothing but a quadrangular pyramid-shaped structure. As you can see here in this image, it is a pyramid-shaped structure which is situated on both the sides of the nose. As you can see in this picture, it is a pyramid-shaped structure. Since it is a pyramid, it will have an apex, a base, and 4 walls. The apex of the orbit is towards the inner side of the eye, and the base is the one which is in the outer part. Moving on to the bones forming the walls of the orbit, as you can see, as I have already mentioned, the orbit is made up of 4 walls, and there are 7 bones which contribute to all these walls. I'll name each bone separately. This is the frontal bone. This is the ethmoid. This is the lacrimal bone. This is the palatine bone, the maxilla, the zygomatic bone, and the sphenoid bone. The 7 bones are forming the walls of the orbit. But it is very difficult for us initially to remember all these 7 names. So is there a way to remember these names? Yes, we have a mnemonic called self-PAMS. You can remember the bones of the orbit with this mnemonic as S stands for sphenoid, E for ethmoid, L for lacrimal, F for frontal, PA for palatine, M for maxillary, and Z for zygomatic bone. I hope this mnemonic will be helpful for you to remember the bones of the orbit. Moving on to the walls of the orbit, as I've mentioned, all these bones together form the 4 walls of the orbit. The 4 walls are the medial wall, medial meaning it is towards the center of the nose, and the lateral wall, which is meaning it is away or outward in the eye, and the roof and the floor. Also, speaking about the base of the orbit, it is nothing but the anterior open end of the orbit, which is bounded by these bones and its margins. Why is it important for us to know all these structures and bones and these walls? Is that, see, the medial wall is the thinnest wall. So it is easily fractured during injuries and surgeries. Take a look at this picture, which is showing some cavities around the eye. These are nothing but the sinuses. Sinuses are air-filled cavities which are present in the skull bone. As you can see, I have mentioned the three sinuses which are around the orbit. The frontal sinus, which is present near the roof of the orbit, the ethmoid sinus, which is present near the medial wall of the orbit, and the maxillary sinus, which is present in the floor of the orbit. Since the medial wall being very thin, any infection of this ethmoid sinus can easily break into and spread to the orbit, leading to the formation of orbital cellulitis. Now, it's time for you to think. I have a question. A fracture occurring in the floor of the orbit is usually called as dash. A blowout fracture. I'll tell you the explanation. Like when there is a blunt trauma to the eyeball, like this, as shown in this picture, a ball coming and hitting in the eye directly, there will be a direct force that is exerted on the eyeball. Since the inferior wall is little thin, not as thin as the medial wall, but this is also a thin wall, it can easily give away and leading to fracture of the floor, and the contents of the orbit can get out of the orbit. As you can see in this picture, now, if there is a floor of the orbit fracture, the contents of the orbit will leak into the maxillary sinus. So as you can see, when the contents of the orbit come into the sinus, all the muscles of the orbit will also get entrapped in the fractured site. So when you check for the extraocular movements in this patient, as you can see, this is the normal eye where he is able to see up, but this eye has an inferior orbital wall fracture, which the muscle is trapped here, so the eyeball is not able to look up. So it is always important for us in any case of any trauma to the eye or the orbit to check for any the intactness of the orbital rim. We have to palpate for the intactness of the orbital rim and also check for its tenderness. And it's always a must to look for the extraocular movements in these cases. Now, talking about the orbit, and the last part will be the apex of the orbit. As we have seen, we have already talked about the base of the orbit. The innermost part where all the four orbital walls converge is a point called the apex of the orbit. It has two important openings. The first one is the optic canal. The optic canal is the main one because through which the optic nerve passes. The second one is the superior orbital fissure. It is nothing but a opening or passage through which all the other nerves and vessels which are coming in and out of the eyeball will pass. So talking about the contents of the orbit, as we have already seen, it is a bony orbit which will enclose the eyeball. So the main content of the orbit is the eyeball and all the extraocular muscles which is surrounding the eyeball. The nerves, as we have already discussed, the optic nerve or the second cranial nerve, which is the important nerve which is most important for the vision of the patient. Other nerves are the third, fourth, sixth cranial nerve and few branches of the fifth cranial nerve, which will pass through the superior orbital fissure. The blood vessels which are coming are ophthalmic artery, which will come along with the optic nerve through that optic canal. And the veins are the superior and inferior ophthalmic veins, which will pass through the superior orbital fissure. And more other content is like the eyeball is covered fully by fat. Moving on to our next topic, the eyebrows. Eyebrows are formed by several rows of hair. They just separate the upper eyelid from the forehead. They contribute to the facial expressions by their movement. Moving on to the next topic, we have the eyelids. Eyelids are nothing but a mobile tissue curtains which are placed in front of the eyeballs. As you can see, there are two parts of an eyelid. which is divided by the horizontal furrow here. It is the orbital part and the palpebral part. The part of the eyelid which is present just in front of the orbit is called the orbital part, and the part which just covers above the eyeball is called the palpebral part. Position of the lids is very important. When eye is open, the upper eyelid covers about 1/6 of the cornea. That is, approximately it covers about 2 mm of the cornea, while the lower lid just touches the cornea. This is important clinically because the drooping of upper eyelid, that is, as you can see here, it is just covering the 1/6 of cornea, and here it's just touching the limbus. But as you can see, this is not similar to this. There is a drooping of eyelid. The drooping or a falling of upper eyelid, this is called ptosis. And as you can see in this image, an incomplete or defective closure of eyelids is called lag ophthalmos. As you can see here, when the patient is asked to close his eyes, he is able to close it fully. But as you can see here, there is a mild defect. Moving on, we have the canthi. As you can see, we have two eyelids, the upper and lower eyelid. The upper and lower eyelid meet each other at the medial canthus, that is in the towards the nose is the medial canthus, and the lateral canthus, which is in the the outer side or the side which will face the ear. So next we have the lid margin. Margin is nothing but, see, as you can see, the end of the eyelid is the eye margin, which is then shown in this picture. It is 2 mm broad, and it also has two parts. This is the lacrimal punctum, which is shown in this red dot. So the part which is present inside the lacrimal punctum is called the lacrimal portion, and the part which is present outside the punctum is called the ciliary portion. As the name suggests, cilia means hair. So the ciliary portion of the eyelid margin will all have the eyelashes. Now it's again time for you to think. The voluntary closure of eyelid, like winking, forceful closure, is done by which muscle? Levator, orbicularis oculi, superior oblique, and superior rectus. You can choose your option. There is a small confusion between the levator and the orbicularis muscle, I guess. The levator muscle we'll be talking about in a few slides. It is nothing but it's an elevator of the eyelid. The correct answer would be orbicularis oculi muscle, which is responsible for the closure of eyelids. As you can see, this muscle is called the orbicularis oculi, which is supplied by the facial nerve or the seventh cranial nerve. So we'll move on to our next slide, talking about the glands of the eyelids. The glands of the eyelids are also very important in clinical aspects. The first gland we are going to see is the meibomian gland. The meibomian gland, as you can see in this picture, is situated on the inner side of the eyelid and opens into the lid margin. It is a modified sebaceous gland which will secrete. Sebum means an oily or lipid structure, secretion. So the meibomian gland will secrete the lipid layer of the tear film. I'll talk about the layers of tear film in a few slides. Next, we are going to be seeing about the glands of Zeiss. As you can see, it is present near this is an eyelash follicle. So we have the glands of Zeiss, which is present near the eyelash follicle and opens into the eyelash follicle. This is also a sebaceous gland. The next gland we have is the gland of Mole. This is a sweat gland, which is situated near the hair follicle. We also have some accessory lacrimal glands, which is present in the eyelids, which we'll be talking about it in the lacrimal system. The glands of eyelids is important. Why is that? As you can see here, the gland of Mole and gland of Zeiss is situated very close to the hair eyelash follicle. As you can see here, any infection of this glands or the lash follicle is called hordeolum externum. For to avoid the confusion of like hordeolum externum, internum, I'll make it very simple to you. As you can see, the lash follicle, which is present on the outside of the eyelid, any infection of this, which is present on the outside, will lead to hordeolum externum, as you can see in this image. infection of the eyelash follicle and associated gland of Moll's disease. Next. Similarly, an infection of a meibomian gland, which is situated on the inside of the eyelid, is called as hordeolum internum. Inside is internum. So you can remember it like that. Infection of the meibomian gland. So you can see here. Next one is that it is non-infective, just a blockage of the meibomian gland. Since it secretes a sebaceous material, when it's blocked, the material gets collected, which will lead to formation of a chalazion. As you can see, it is non-infective inflammation caused by blockage of the meibomian gland orifice and stagnation of the secretions. And just to touch upon the clinical anatomy of the eyelids, an eyelid which is turned inward towards the eyeball is called an entropion, and an eyelid which is turned away from the eyeball, is called an ectropion. And as you can see in this picture, the eyelashes which are turned in and touching the eyeball is called as trichiasis. So moving on to our next topic, the lacrimal apparatus. As you all know, lacrimal apparatus is the main function of it is to secrete the tears, which I'll be telling in a few slides. The lacrimal apparatus consists of three main parts: the main lacrimal gland, the accessory lacrimal glands, and the lacrimal passage. The main lacrimal gland, as you can see in this picture, is located in the lacrimal fossa in the orbit. Consider this as the margins of the orbit. So this is in the roof of the orbit, there is a fossa in which the lacrimal gland is situated. So it has two parts, the orbital part and the palpebral part. The part which is present near the orbit bone of the orbit is called the orbital part, and the part which is present near the eyeball is called the palpebral part. And there are many ducts, around 10 to 12 ducts, which pass from the lacrimal gland and through which the tears is secreted and will open into the superior fornix. Moving on to the accessory lacrimal glands, we have two glands, glands of Cross and gland of Wolfring. As you can see in this image, gland of Cross is situated near the fornix and opens into the fornix. And gland of Wolfring is situated on the inner margin of the eyelid, and it is in close relation with the tarsal plate. And moving on to the lacrimal passage, after the tear is secreted from these structures, it has to be drained from the eye. Through the passage which I am about to tell, it has a punctum. Punctum is nothing but a small opening which is present on the eyelid margin. From there, we have the canaliculae, two canaliculae, that is the superior canaliculi, the inferior canaliculus, which joins together to form the common canaliculi. From there, it opens into the lacrimal sac, and from there, it continues as the nasolacrimal duct. Now, we have a question again. The distance of upper punctum and lower punctum from the medial canthus is dash and dash respectively. That is, from the medial canthus, what is the distance of the upper and lower punctum? As you can see, it is either the upper punctum and lower punctum 6 mm, upper punctum 6.5, lower is 6.5 mm, the upper is 6 and lower is 6.5 mm, or vice versa. Please select your answers. Here also we have small confusion from the option A and C. Okay. We'll see what is the correct answer. As you can see in this image, the upper punctum is located 6 mm from the medial canthus, and the lower punctum is located about 6.5 mm from the medial canthus. This question was just to play with the numbers and for you to remember these values in an easier way. Next, moving on to the canaliculi, as I already said, there is a superior canaliculus and an inferior canaliculus, both of which have a horizontal part and a vertical part. It starts with the vertical part and continues as the horizontal part and joins with the other canaliculi and forms the common canaliculus. The vertical part is about 2 mm in length and the horizontal part is about 8 mm in length, and both of them are situated at right angles to each other. That is, it makes a 90-degree angle. We have to know this angle because while checking for the patency of the duct, when we pass the syringe, we have to keep in mind that there is a bend over here. After the formation of a common canaliculus, it drains into the lacrimal sac, which is about 4 to 5 mm wide and continues down into the nasolacrimal duct. The nasolacrimal duct approximately measures 18 millimeters, which can range from 12 to 24 millimeters. So as we have already told, tear film is an important structure to be discussed. It is not just a watery thing which comes out of the eye. The tear film is a three-layered structure and each layer has an important function to it. The innermost is the mucin component, the middle is the aqueous component, and the outermost is the lipid layer. The innermost mucin component is secreted from the conjunctival goblet cells. The middle aqueous component, as we have already discussed, comes from the lacrimal gland. Both the main and accessory lacrimal gland secretes the aqueous component of the tear film. And the superficial or the outermost lipid layer is secreted from the meibomian glands, the glands which we have already seen in the eyelids. So the main functions of tear film is to keep the cornea and conjunctiva moist. It provides oxygen to the corneal epithelium, washes away any irritants or debris, prevents infection due to the presence of antibacterial substances, and for easy movement of the eyelids over the globe. So for you to recollect, tear is getting secreted from the main lacrimal gland and accessory lacrimal gland. From the main gland through the lacrimal ducts, it passes into the fornix. The aqueous component will come from there. And here, the mucin component will come from the conjunctiva and the lipid component will come from the eyelid meibomian gland, and all the three layers are formed which will spread over the ocular surface. And from the ocular surface, it will enter the lacrimal punctum during blinking and will go into the superior and inferior canaliculi, which will join to form a common canaliculi. From there, it gets drained into the lacrimal sac. From the lacrimal sac into the nasolacrimal duct, which will then open into the inferior meatus of the nose. I hope this is very clear to you. This is to tell that we have seen the flow of tears. What if there is a blockage in the nasolacrimal duct here? If there is a block here, the fluid will get accumulated in the lacrimal sac and the secretions which cannot be drained again. Like once it is blocked, no more secretions can go into. So there will be continuous watering in the patient. The complaints of the patient will mainly be continuous watering. When that is a long-standing blockage, the fluid which is collected here will get infected and will form into a discharge or pus. So the patient will have pooling of discharge near the medial canthus. And when we check, this is what we check by the Roplas test. When we give pressure over this area, if there is regurgitation of any fluid or pus, is what we see in the Roplas test. So I'm going to be talking about extraocular muscles next. Extraocular muscles, as the name suggests, extra is outside, ocular is eye. So these are the muscles which are present outside the eyeball. Each eyeball has 6 extraocular muscles, namely the 4 recti muscles and the 2 oblique muscles. The 4 recti muscles are the superior rectus, the inferior rectus, the medial rectus, and the lateral rectus. And the 2 oblique muscles are the superior oblique and the inferior oblique. And this point, as you can see, eyelid movement is controlled by levator palpebrae superioris. This is elevation of the eyelid is done by levator palpebrae superioris. There was a slight confusion in the poll which was conducted previously, like which is the muscle responsible for the movements of eyelid. Voluntary closure and forceful closure of eyelid is done by orbicularis muscle. Elevation or opening of the eyelid is done by the levator palpebrae superioris muscle. Whenever we talk about a muscle, we have to talk about the origin, the insertion, and the nerve supply of the muscle for us to understand the action of the muscle. So speaking about the origin, all of you please concentrate on this first image. As you can see here, this is the image of the orbit. And the inner part of the orbit, as you can see, this is the apex of the orbit. I hope you all remember the apex of the orbit has two openings, the optic canal and the superior orbital fissure, which is like zoomed here. Can you see the optic canal and the superior orbital fissure? There is a fibrous ring-like thing attached to this, like covering the optic canal and superior orbital fissure, which is called the annulus of Zinn. You should like remember this name because it is very significant. The name, it is annulus of Zinn. This is where the recti muscle take its originate from. As you can see in this image, this is the annulus of Zinn, which is shown in this image. As you can see, there is a superior rectus muscle, the inferior rectus muscle, the medial rectus muscle, and the lateral rectus muscle. All these muscle start its origin from this tendinous ring. And in this image, as you can see, once it is originated, it moves forwards in its respective directions. And the oblique muscles, to note upon, the superior oblique comes from the roof, near the roof of the orbit, and the inferior oblique takes its origin near the floor of the orbit. All these muscles pass forwards and encloses the eyeball, and the four recti muscles are inserted into the sclera. As you can see, the superior rectus, the medial rectus, the inferior rectus, and the lateral rectus. I have mentioned these numbers here because each muscle is not like all the muscles are not attached in an equidistant from the limbus. This is the limbus, which is the end of the cornea. Each muscle has a specific distance from the limbus where it is attached. Very important is the superior rectus insertion, which is like 7.7 mm from the limbus. Because while doing the small incision cataract surgery, usually we take a superior rectus bridle suture for stabilization of the globe. It has to be kept in mind that it is 7.7 mm from the limbus. And as you can see, the superior oblique muscle, as the name suggests, it's the oblique muscle, means it is coming in an oblique fashion and getting attached into the upper outer part of the sclera like this. And the inferior oblique muscle comes and attaches into the lower and outer part of the sclera. Talking about the nerve supply of these muscles, it is always confusing. So it is easy to remember this mnemonic: SO4, LR6, and all others 3, which will be explained as superior oblique is supplied by the fourth cranial nerve. The lateral rectus muscle is supplied by the sixth cranial nerve. So the two muscles we have already told, superior oblique by the fourth and lateral rectus by the sixth. So the remaining four muscles, that is the inferior oblique, the medial rectus, the superior and inferior rectus, are all supplied by the third cranial nerve. Moving on to the actions of the extraocular muscles. Uh, as you can see in this image, we'll talk about the medial rectus first. Medial rectus, when it contracts, it pulls the eyeball inwards or towards the nose, which is called as adduction. And inward or towards the nose, it is getting tilted, called the adduction. When lateral rectus constricts, it pulls the globe away from the nose or in outward direction, which is called abduction. When the superior rectus muscle constricts, it pulls the eyeball upward, called the elevation. And similarly, the inferior rectus, when it constricts, pulls the eyeball downward, which is called the depression. The obliques are little difficult to understand, so I'll try to explain. The superior oblique muscle, as you can see, comes from its origin, hooks over this trochlea or a pulley and gets attached in the upper and outer part of the sclera. As you can see, it goes like this. So when superior oblique muscle contracts, it will pull the eyeball or it will rotate the eyeball inward. This rotating of eyeball inward or towards the nose is called the intorsion. It will turn the eyeball as a whole inward. And similarly, the inferior oblique muscle, as you can see, is coming like this and getting attached in the lower outer part of the sclera. So when this muscle contracts, it will it will rotate the eyeball in an outward direction or away from the nose. Like this is the rotation of the eyeball, which is called the extorsion. The main importance for us to know all these extraocular muscles and their actions is this. For any case, as I already told in the orbit, for any fractures or any case, it is important for us to look for the extraocular movements of the eye. This is the primary position from which we'll tell the patient to look in the different or 9 gazes to look for the extraocular movement. It can also be the individual muscle action can also be checked on this extraocular movement by telling the patient to trace. We have to trace a letter H. Telling the patient to trace a letter H. As you can see, when you tell the patient to look here or towards the nose, we are checking the medial rectus. When you are telling the patient to look in this side or away from the nose, we are checking the lateral rectus. Similarly, if we tell the patient to look out and from there look up, we are checking the superior rectus, and from look out to look down, we are checking the inferior rectus. The obliques are always confusing. So remember, the obliques are always reversed. So when you tell the patient to look in and up, it is the inferior oblique. Though the name is inferior, we are telling the patient to look up here. And superior oblique is tested by telling them to look in and down. One more importance for these, the movements of the eyeball and things, is the Hitzberg test or the corneal reflex test. I think most of you will know what this test is. If you shine a bright torch in the center of both the eyebrows, the normal corneal reflex will be seen in center of the pupil, as you can see in this picture. All these are squint or strabismus. The corneal reflex will not fall on the center of the pupil. As you can see in this image, it is falling on the lateral or the outward margin of the pupil, which is signifying the eyeball is turned inward. So hence the name esotropia. Inward is esotropia. As you can see in this image, the light is falling on the inner margin of the pupil, signifying the eyeball is turned outward. As you can see in this image, when the eyeball is turned outward, it is exotropia. And you can see in this image, the reflex is falling on the inferior margin of the pupil, telling that the eyeball is turned or rotated upward, which is called upward is hyper. Hence the name hypertropia. And in this image, it is the vice versa. And the eyeball is turned down, which is saying it is hypotropia. So moving on to our last topic of this session, conjunctiva. Conjunctiva is nothing but a translucent mucous membrane which lines the posterior aspect of the eyelid and the anterior aspect of the eyeball. It extends from the lid margin, that is, it starts from the lid margin, goes throughout the posterior surface of the eyelid and goes over the eyeball and ends at the limbus. The space which is enclosed by this conjunctiva is called the conjunctival sac, and it is opening in the front as the palpebral fissure. I'll explain the palpebral fissure in the next slide. As you can see, the parts of conjunctiva are the palpebral conjunctiva, the bulbar conjunctiva, and the fornix. As you can see, palpebral conjunctiva is nothing but the one which lines the posterior surface of the eyelid, as you can see here. The bulbar conjunctiva is the one which is present over the eyeball, as you can see here, and between the both is the fornicial conjunctiva. And as I told, palpebral fissure is nothing but the opening which we see out. The eyelid margin is making an opening which we see out, which is called the palpebral fissure. To elaborate on the palpebral conjunctiva, which is again divided into 3 parts, as you can see, palpebral conjunctiva is the one which is present on the posterior surface of the eyelid. It has 3 parts, the marginal, tarsal, and orbital conjunctiva. As the name suggests, marginal is the one which is close to the lid margin. The tarsal one is present near the tarsal plate, and orbital conjunctiva is the one which is present near the orbit. And the bulbar conjunctiva is the one which is enclosing the eyeball, and between the two or connecting the two is the fornix or fornicial conjunctiva. To touch upon the glands of conjunctiva, we have already discussed about the accessory lacrimal glands in the lacrimal system, which is the glands of Cross and Wolfring, which is present near the fornix, which is responsible for the aqueous component of the tearfilm. Moving on to the main glands of conjunctiva, which is the mucin secreting glands. As we have already told, it forms the mucous layer of the tear film or the innermost layer of the tear film. which is secreted from the goblet cells, which is present here, and glands of Mans, which is present here, and some crypts of Henle, which is supposed to be here. As we talk about the conjunctiva, it is very relevant for us to talk about the conjunctival congestions and the different types of congestion. As you can see in this first picture, this is just a conjunctival congestion, which is the redness which is present more in the palpebral conjunctiva and throughout the eyeball, which is most commonly seen in conditions like conjunctivitis, any conjunctival foreign bodies. The next one is the circumcorneal congestion or the ciliary congestion, which is that congestion which is present more near the limbus of the eye. This is more commonly seen in any inflammation or any conditions within the eyeball, like any iritis, iridocyclitis, any scleritis, etc. A mixed congestion is the one which both conjunctival and circumcorneal congestion is present, which is most pronouncedly seen in corneal disorders like corneal ulcer, corneal epithelial wounds, and intraocular irritation will be present in these patients. Moving on to the subconjunctival hemorrhage, as you can see, it is a well-defined collection of blood under the conjunctiva, hence the name subconjunctival hemorrhage, which is commonly caused due to trauma or violent eye rubbing, which rarely it can also be present in patients with high BP and violent coughing. Talking about the conjunctival congestion and conjunctivitis, it is very important for us to differentiate papillary conjunctivitis from follicular conjunctivitis. As you can see in this picture, and this picture is the papillary conjunctivitis. A papillae is nothing but an elevation in the corneal epithelium, which will have a central blood vessel and surrounded by inflammatory cells, which is most commonly seen in allergic and bacterial conjunctivitis. It has a velvety red appearance because of its central blood vessel. Next, we move on to the follicular conjunctivitis. As you can see, this is also an elevation in the conjunctival epithelium, but it has only the collection of inflammatory cells as the major thing. So in this image, as you can see, it is a flat-topped, whitish elevation. This is most commonly seen in viral conjunctivitis. So it is always better for us to differentiate a papillary conjunctivitis from follicular conjunctivitis because the treatment modalities will differ with each. So also to touch upon some of the other applied or clinical aspects in conjunctiva, as you can see, the abnormal growth of conjunctival tissue over the cornea is called as pterygium. And also, can you spot out in this picture, there is a small foreign body present in the upper tarsal conjunctiva. So this is a very small foreign body which will be seen unless we avert eyelid and see. So whenever a patient presents to your clinic with redness or irritation in the eye, always avert the eyelid and look for small foreign bodies in the upper tarsal conjunctiva or the lower fornix, which should not be missed. With this, I end my presentation about the orbit and appendages of eye. I hope all of you are clear about your basic anatomy in these structures. Thank you. Thank you, ma'am.